Christmas and a Happy New Year. Last week, Dr. Aditya took this session. We have started the session 100 days to 100th percentile for NEET SS. And if you have attended the earlier session that was conducted by Dr. Aditya, that session focused mainly on the frequently asked topics and questions related to NEET SS, and also here and there some topics that are asked in INISS, right? Because INISS is also not that far away, and frequently there is a commonality in between the two, the most competitive exams, right? So in this session, we are going to deal with 6 questions, and primarily questions related to pediatric neurology. And we are going to explore the frequently asked topics or the sections in these 2 exams, right? So without further ado, can we start this session? If the audio and video is fine, then we can go ahead with the session, right? So let's begin. The first question that we have here with us is an image-based question. So we have a child that presented with fever, seizures, and encephalopathy. The MRI is shown below, and they ask what is the cause of cerebral edema in this case, right? This is cerebral edema. Cerebral edema in this case. What is the cause of cerebral edema in this case, right? And the options we have here are vasogenic edema, failure of sodium potassium ATPase pump, cytotoxic edema, and obstructive hydrocephalus, right? By common sense, you can actually rule out the options out here, even if you don't know what are the causes of cerebral edema, what are the types of cerebral edema. You can simply by common sense rule out options, right? You can't see any obstruction out here, no obstructive hydrocephalus features out here, so definitely this is not the correct option. And we all know that in cytotoxic edema, there is metabolic failure and hence causing a failure of sodium potassium ATPase pump. So both these 2 options, option B and option C, essentially mean the same thing, right? And we have to choose one. So definitely these 2 are wrong. The correct one here is vasogenic edema, right? So as you can see in this picture, fever, seizures, encephalopathy, and a typical intracranial space occupying lesion is seen, as you can notice here. And surrounding that lesion, there is cerebral edema, right? And that could be the cause of seizures, encephalopathy, right? So in this question, they're asking what is the cause of the cerebral edema. So for beginners, cerebral edema, we have 4 types. Right? We have cytotoxic edema. We have vasogenic edema. Right? We have interstitial edema that is also associated with hydrocephalus, also known as hydrocephalic edema. And lastly, we have osmotic, right? So cytotoxic edema is in metabolic failure whenever there is anoxia, ischemia, right? So resultant metabolic failure would lead to the failure of sodium potassium ATPase pump. And because of this failure of sodium potassium ATPase pump, there will be influx of sodium, water, right? So there will be edema, right? And this edema fluid is going to have sodium, water, and what is important here is the edema won't have any protein in it, right? There will be just water, sodium, that's it, right? And in vasogenic edema, what happens is there is breakdown of your blood-brain barrier. So the integrity of this blood-brain barrier is affected, and because of that, there is resultant increased capillary permeability, and it is essentially the ultrafiltrate of the plasma that is causing the edema, right? And that's why this fluid is going to be very high protein rich, and this type of edema is seen in tumors, infections, like the earlier picture that we have seen, in cases of trauma, right? In fact, in high altitude cerebral edema also similar picture is seen. Then we have interstitial or hydrocephalic edema. This is due to hydrocephalus. What happens in hydrocephalus? The volume of CSF increases, and because of that, what happens? There's going to be flow of CSF through the there will be trans-ependymal flow of CSF into the periventricular extracellular space, and that leads to edema. And lastly, we have osmotic edema. This is seen in conditions where there is hypernatremia, in conditions like SIADH, where due to this change in the osmolality, there will be influx of water, right? So here in this case, the picture is suggestive of tuberculoma, and the edema that we see here is nothing but vasogenic edema, right? So here's a table differentiating the 4 types of edema: cytotoxic, vasogenic, interstitial, and osmotic, right? And we should know that the high protein fluid is seen in vasogenic edema, right? So this is all about the types of cerebral edema. Use your common sense, and such type of questions will be really easily answered, right? So coming down to the next question. So there's a pattern that I've seen in the recent INI and NEET exams, that they have been asking more and more about refractory seizures, more and more about new therapeutic modalities, more and more about epilepsy surgeries, right? So one such questions that I encountered in the recent INI is about cannabidiol, right? They asked that cannabidiol is effective in, and they effective in all except such type of question, and they have these type of options. So the options were Lennox-Gastaut, Dravet, tuberous sclerosis, and ataxia telangiectasia, right? So cannabidiol is again a reserved drug, and recently we have FDA has approved this medical cannabis, cannabidiol, for 3 conditions for pediatric patients that are 1 year or older. And the 3 conditions are LGS, Dravet, and TSC, that is tuberous sclerosis complex. For ataxia telangiectasia, no such trial or efficacy have been proved. So it is important for you to learn that this cannabidiol is approved for 3 conditions: LGS, Dravet, and tuberous sclerosis, right? And the brand name is Epidiolex. That is the first and the only FDA approved prescription cannabidiol that is used to treat seizures associated with LGS, Dravet, and TSC in patients 1 year of age or older, right? So this is about the second question. Moving down to the third question, again about the refractory seizures and the surgical modalities that we use for the treatment of epilepsy. The question is about deep brain stimulation. So the question was on the lines like deep brain stimulation is most effective in progressive dystonia with normal basal ganglia, progressive dystonia with abnormal basal ganglia, non-progressive dystonia with abnormal basal ganglia, or non-progressive dystonia with normal basal ganglia. I can see some people are live here watching. So can you attempt this question about deep brain stimulation, surgical modality to treat seizures? I can see Dr. Rishi has answered A. Indeed, you are right, Dr. Rishi. It's progressive dystonia with normal basal ganglia, right? We all know that dystonias are of 2 types. Dystonias are of 2 types. We have primary dystonias. Just a second. Yeah. So we have primary dystonias and secondary dystonias. Primary dystonias are the genetic causes of dystonias, where you have an underlying genetic mutation that is responsible for this dystonia. And we have secondary dystonias where there is some insult to the brain, right? And because of that, we have dystonias. So eventually in dystonias, firstly, we do medical management. And if medical management fails, then in some cases, this deep brain stimulation, which is indeed an invasive modality, is used. What do we do in deep brain stimulation? Stereotactically, a pulse generator is inserted, right? Stereotactically, a pulse generator is inserted down. and it was found particularly effective in Parkinsonism patients, where the insertion was done in the globus pallidus, right? In the globus pallidus interna, this was done, right? So, for answering this question, that you can see the options have particularly two things. We have whether this dystonia is progressive or non-progressive, and whether there is abnormal basal ganglia or there is normal basal ganglia. The screen, is the slides lagging or my video lagging where you can see my face? Is it fine now? Can we go ahead? So, so till now we have learned that what happens in deep brain stimulation. Uh, we stimulate. It is a surgical method, definitely invasive method. We have to stimulate your deep brain areas that are considered to be the generator, right? First of all, it is seen that in progressive conditions, deep brain stimulation, the sound is lacking, not matching with the video. Is it fine now? Is it fine now? Is it fine now? Okay, so we are moving ahead. Can we move ahead? Kindly give me a heads up or a reaction so that I can know if we can move ahead. Okay, so finally, the question here is whether it is the progressive dystonia and do we need an abnormal structure or normal structure, right? So it is seen that this deep brain stimulation is more effective in primary dystonias, right? Primary dystonias means there is some genetic problem and not any structural problem. So one thing I'm sure is the basal ganglia is going to be normal. Basal ganglia is going to be normal. No structural defect is going to be there, right? And in non-progressive conditions, medical treatment is better. Deep brain stimulation is not found that effective, right? So the correct answer here is progressive dystonias with normal basal ganglia. It is a clear-cut statement given in Nelson that in primary dystonias, this deep brain stimulation is more effective. It is less effective in conditions where there is some clear-cut insult to the brain or the secondary dystonias, right? So similarly, in this question, you can clearly answer that it is the progressive dystonias with normal basal ganglia that would be effective. If you look at the other conditions, like progressive dystonia with abnormal basal ganglia. In these conditions, most likely the cause is some new underlying neurodegenerative disorder, and it is seen that DBS has less favorable outcomes because in neurodegenerative conditions, broader neural networks are affected. In conditions with non-progressive dystonia with abnormal basal ganglia, like abnormal basal ganglia, that means there's some insult. It is most likely due to perinatal injury or strokes, that is secondary dystonias, right? In these conditions also, DBS outcome is variable and generally very less robust as compared to primary dystonias. And the last is non-progressive dystonia with normal basal ganglia. It also includes certain metabolic disorders, and again, the outcomes are very less predictable, right? So the most appropriate answer here is answer A, that is progressive dystonias with normal basal ganglia, right? Moving down to the next question, we have another modality for refractory seizures, that is mechanism of action of vagus nerve stimulation. Vagus nerve stimulation, right? And the options are locus coeruleus, dorsal vagus nuclei, nucleus accumbens, or all of the above. They're asking at which point, what is the main region involved in this mechanism of action. Vagus nerve stimulation is done in cases of refractory seizures, and how it acts, that's the essence of the question. And they have given anatomical structures, and they're asking you what is the major structure that is involved in this mechanism of action, right? And we have different structures that are somehow linked to the vagus nerve, and they're asking about the pivotal structure that is involved in the hair, right? So anyone can anyone answer it down, that what is the major structure involved here? Here also a generator is attached to the left side of the vagus nerve, and through that the specific seizure generator area is aborted, right? So what would be the correct answer over here? It is a very recently asked INI question, and similar neurotransmitter related question have been asked in NEET also. So I believe this is again an important modality over here. Okay, so I can see a lag. So the correct answer over here is locus ceruleus. Locus ceruleus, right? So what is the essence here in vagus nerve stimulation? This vagal nerve stimulation with, in fact, how it will work, the pacemaker will send signals, repetitive signals, and that would modulate the brain activity through the connections uh, of this vagus nerve with the brain stem and other regions, right? Here it is seen that locus ceruleus is the focus, the pivotal area, the brainstem nucleus that is involved in the norepinephrine release, and it also modulates attention, arousal, and also seizure control that we are using it for, right? Dorsal vagus nucleus, although vagus nerve is connected to this, but it is less directly implicated in the therapeutic effects. And similarly, nucleus accumbens, it is the region that is involved in your reward area and also the mood regulation, right? Vagus nerve stimulation may indirectly influence it through the limbic system, but definitely not for the seizure control, right? So the major area that is involved is locus ceruleus through norepinephrine release, right? They can ask you about the neurotransmitter, that is the norepinephrine, or they can ask you about that area, particular area, right? So the best answer out here is going to be locus ceruleus, right? Moving down to the next question, intent eye gaze. Intent eye gaze. I intentionally put this question out here, not because it was a recently asked question, but also a similar newer modality could be asked, right? The question here is, the intent eye gaze is seen in which of these conditions? We have creatine deficiency syndrome, Rett syndrome, Fragile X syndrome, or Angelman syndrome. The question is intent eye gaze, that is intentional eye gaze, purposeful eye gaze is seen in which of these syndromes? Can anyone try and answer? Intent eye gaze is actually the use of eye movements as a means of communication, right? And this is often seen in individuals who have some sort of motor impairment, and also so they can't use their hand gestures to communicate. Also, they have some speech issues, so they can use their speech also. So they use eye movements or eye gestures to express themselves, right? So intent eye gaze is nothing but the use of eye movements as a means of communication, right? So the correct answer over here is Rett syndrome. Rett syndrome. It is actually a very characteristic feature of Rett syndrome. They show very purposeful eye gaze to express their interest, or despite uh, their limitations. We all know that in Rett syndrome, there is significant motor regression, and eventually they lost their speech also. So how can they communicate, right? We also know the stereotypic hand movements that we notice in Rett syndrome. So these Rett syndrome children cannot express themselves using hand gestures or the motor movements, and also the speech is affected. So they cannot verbally express also. So in these cases, it is the eye gaze, the intent eye gaze. They use characteristically this gaze for communication, right? And why this is important for us? Because all technologies, alternative communication technologies that use these eye movements to communicate are being developed, right? So a Rett syndrome child, if wants to express something out loud, they cannot use their speech or motor movements. So this, through this alternative communication technology that is linked to their eye gaze or eye movements, we can definitely perceive whatever they're trying to call, right? So definitely an important question. If you look at other conditions, in all other conditions also we see developmental delays and seizures and overall intellectual disability, but none of these conditions intent eye gaze is a characteristic feature. When we talk about Rett syndrome, then in that case intent eye gaze is a very characteristic feature, right? Now, moving to the last question. So this question, again, a clinical scenario based question related to dystonia movement disorders. So a very interesting clinical stem is there. We have an 8-year-old boy who presented with complaints of intermittent twisting movements of the head, neck, and upper extremities. And father of this child also experienced some similar movements, and these movements improve upon alcohol ingestion, right? Father tells whenever he intakes alcohol, these movements they improve, right? And so what do you think which gene would be affected over here? We have series of genes, DYT12, DYT11, DYT23, and DYT1, right? What do you think would be the correct answer? It is one of the inherited dystonias that improve upon ingestion of alcohol. What is the correct answer over here? So if you go back and look at Nelson, there is a beautiful table given of the causes of dystonia that includes all the primary dystonias, hereditary dystonias, as well as non-hereditary dystonias, secondary dystonias, and various dystonias that are related to metabolic causes. So in the section of hereditary dystonias, you can see that uh, in this hereditary dystonias, there are more than a dozen of genes like DYT1 to 24, right? And each of these have some peculiar findings, and one paragraph is specifically dedicated to this clinical stem, right? That affected family members shows improvement upon alcohol ingestion, and there is specific dystonia involving the location, the neck, head, upper extremities, and usually they give a scenario like child was playing football or something involving the upper limb, and suddenly there is twisting dystonic movement, right? We all understand what is dystonia: sustained contraction leading to that torsional twisting movements, right? That's why this dystonia is also known as torsion dystonia, right? So a typical gene that is involved here is DYT11 gene, right? So it is an important clinical stem. So definitely do check out this table that is given down in Nelson. And with this, we complete the sixth section. I'm sure you got a clear picture that what is the recent trend by the examiners. They're asking more and more about the new modalities that you use for refractory epilepsies, right? Surgical neuro epilepsy surgeries, and as well as modalities like deep brain stimulation, vagal nerve stimulation, and movement disorders. Definitely the gene related to various hereditary epilepsies and movement disorders, right? Apart from that, Rett syndrome is yet another favorite topic since the NEET PG days, right? In NEET PG also, we used to get a lot of questions related to Rett syndrome in both INI as well as your NEET exam. Here also, they ask more in depth about Rett syndrome. So, and this is a recent question because a new modality that, as I discussed, alternative communication system technology that uses the eye gaze, right? So, this is yet another important aspect that you need to take care of, right? New modality as well as the newer anti-epileptic drugs. If you happen to go through our uh, schedule, our the list of videos, the topics, I have made a special dedicated videos to newer anti-epileptic drugs, and we have also discussed about cannabidiol, deep brain stimulation, and vagal nerve stimulation in various places wherever we encounter refractory epilepsy, right? If you have any other doubt related to these six questions, set of six questions that we discussed, or on the trajectory of what all do you need to focus on the pediatric neurology section, do drop a comment, and we can then wrap up this session. Finally, all the best for your upcoming exam. I know the exam is quite near, and you must be in your revision phase, consolidation phase, and just focus on the important topics, right? Important topics, important mock test, right? We also have launched mini tests. You can go and give them out. Mini test, by the name itself, you get to know that they have very small questions, very less number of questions, won't take much of your time. So even if you're busy on your duties or you are too tired, you can still go out and give it a try, right? The more you give these mock tests, the more you give these mini tests, the more you will become curious, and also you will get an idea as to what these exams, NEET SS and ISS, expect out of you, right? uh, you don't need to read a specific book for deep brain stimulation and vagal nerve stimulation. Just need to have a brief idea. There are definitely various workshops out there, and various conferences do such seminars on these topics. But at the entrance level, if you are really interested into pediatric neurology, you can definitely go and read in depth about these topics. But for the exam sake, you just need to know a basic background as to what happens in these surgery, and for what all conditions it will be effective, and in what would be the candidates for these procedures, right? And nothing in deep. You don't need to read full books about these procedures, right? Definitely for the ones who are going for neurosurgery uh, must have read a lot about these conditions, but we just need to know that what would be the candidates for these procedures, and in which all conditions it would be effective, right? And we have discussed that in this session only. Don't need to know any further about that. That's for sure. Anything else? Okay, I think no further doubts are there, and we can wrap up this session. So thank you everyone for listening, for being here till the very end. I hope this session helped you in giving an overview of what the examiner is going to expect and what are the topics that you need to focus on. So thank you, and good night. We'll definitely meet over the next coming weekends, and we'll be discussing more topics. And I hope this session is helpful. This initiative, 100 days to 100 centile, helped you a lot. If I know the exam is near, you cannot go and watch all the videos that we have curated for you, but you can definitely go check out the question bank and the mini test. That's the least you can do in this last leg of revision. That would, in my opinion, that would help a lot. Thank you, and have a nice day. Good night. I think we can end the session now.